welcoming you. I am entering my session first. So requesting you, be with your pen and the paper also. If you want to note something, you can note down. And after the practice session become over, I will invite the question answer from you. If you want to ask me or anybody can participate to tell your opinion. Okay. Anyway, I am again actually muting everyone. So be with me and welcoming you. We are Dr. Osman Academy of Medical Science. You already know from last few days. Uh, at first, just to say something about how to introduce a doctor to a patient for fundoscopy to be done. So you see a big text is shown here. And this is actually very, very good courtesy to tell everything. But in the exam situation, we cannot tell everything. But few things we must tell to the patient. It is highlighted in the left side box. I think I can request you to make a snapshot also for these. In my sense, these things should be told to the patient before approaching to a patient for the fundoscopic examination. And these are also you have to go through. And the last one, if we tell about the station 5, driving is always important. You know about the importance of the driving who are practicing PACES in many times. So this is the introduction. Hello, my name is Dr. Such and Such. I have been asked to examine your eyes or back of your eyes. Both can be possible. You can utter the word according to your instruction. Back of your eyes is actually a layman term of the retina. So it depends upon the instruction given. Is it okay? You are taking the permission. Then you are describing how to proceed on. I think it is enough if you go through, that's enough for the practicing doctor. So how to start now? Get ready. I am requesting the candidates to be with us as a virtual classroom. And you are entering now to PACES a station where fundoscopy will be given as a case and we will be discussing. So this is the way, and many books in the many texts written many more things, but simply what will be the best procedure in my sense I'm sharing with you. Just keep your hand before you are introducing yourself, then rest left hand on the patient's, if you want to examine the right eye, left hand on the patient's forehead with thumb extended, and thumb will be a barrier between you and the patient head or patient forehead. And you take your ophthalmoscope in the right hand. I think somebody of you know how to use the ophthalmoscope, matching the lenses of your eye power. So this is the online session. Really, I cannot show you, but you can go through, or some video also can help you from the YouTube. And first adjust your eye power with the lens, and it is advised that just look at your palm creases, because the palm creases are having some similarities with the retinal vessels. So from the ophthalmoscope, if you look to your palm creases and roll your lenses and make a power appropriately focused so that you can see your palm creases, then you may think that these focusing will be enough inside the eye of a person. Even then you have to move up and down with the lenses of the fundoscope. Anyway, okay, then we have to go to check. You start from around 1 hand breadth away from the right side. I think I'm not here to tell about that. So when you start from beginning, you will find a red reflex, and it's very normal. This is the red reflex around 10 or 20 centimeter from beyond. And it's very, very normal. If you find any opacity, you may think that there is some problem in the refractory media up to the retina. So this is the normal appearance, and then this is the opaque area. So this is another diagnosis. Somebody of you know, definitely it might be cataract, might be cataract. So before going inside the retina, we must see any opacity is there or not. So this is a highlighted picture. This is the normal red reflex, and this is the dilated pupil. Usually in the examination, pupils are given dilated by mydriatics. So don't be worried for that. And these are the typical pictures of opacity in the lens actually, and it is the cataract really. So if you find that these are not there and everything is clear, then you can go for seeing retina inside. So I think we can go for the practice session, and some of you really ready for with us to practice one. So with whom we talked before, I think someone interested to do it. May I request Dr. Uddin to be ready for the practice? Dr. Misbauddin. Hello.
Yes, sir.
Can you hear me,
Yes,
please?
sir.
Can you hear me? Okay. So
Yes, sir.
side by side, those who are very beginner, I am requesting you just follow us. In the practice session, you will learn a lot. You will hear us actually how a doctor is to talk to the patient and how the informations are being given, and those who are actually experiencing in future for the part 2 also, you just follow that what information will be the very key informations in a scenario like this today. So ideally what should we do, a candidate will come into the station like PACES and talk to the surrogate, and in practically really I will be the surrogate, and total time will be given for 1 minute will be given to read the instruction. After 1 minute, doctor is to start talking to the patient. It will be station 5, a complete short consultation station. So doctor will be initially given 7 minutes time. I think enough. Dr. Mesbah, what do you think? 7 minutes is enough. And then 2 minutes
Okay, sir.
extra to conclude the consultation. So usually 2 minutes left will be sounded and candidate will finish talk with the patient really, the surrogate. And examiner will have 2 minutes extra time to discuss with the doctor. So how much we can do, let us see. In the meantime, my dear participants, you can have your notebook with you. If you have any question, you can ask after the session become the first session become over. We will give you time to discuss about that. I think Dr. Mesbah is ready. Okay, so get ready, please. Other candidates are requested to keep your switch off, audio off, please. So Dr. Mesbah, I'm giving you the scenario for you. 1 minute. Are you ready?
Okay, sir.
Okay. So this is the scenario, maybe like this in the station 5. Start the reading and we will start after 1 minute time. And all of the participants, please try to think your best. What could be the diagnosis of such scenarios? What may be the possibilities, maybe differentials also you can think of. If Dr. Mesbah is ready, please let me know so that we can start smoothly. Some basic observations also given to you. So this is acute blurring of the vision in a young lady, and she is also diabetic patient, possibly type 1 diabetes. And now you are instructed to talk to her. Special attention should be given to the fundoscopic examination.
Okay, sir.
Okay, enter please.
Hello, good evening. I'm Dr. Uddin, one of the doctor in the endocrinologist clinic. Are you comfortable here?
Good evening, doctor. Yes, doctor. Yes, your environment is nice.
Okay. And I came to know that you are having some problem with your vision. Can you tell me more about this?
Yeah, doctor, everything was fine. Suddenly today morning actually, I feel pain in my left eye. And a few minutes after, I observed that I cannot see with my left eye. Till now, it is persisting, doctor. I took some paracetamol for pain relief. A little pain relief, though, but I'm not feeling well, doctor. But doctor, I'm a patient of
Okay,
diabetes. I'm patient of diabetes for the last 5 years. I'm taking the treatment of these, and I'm on insulin treatment. And my blood sugar also, everything is okay. Last checkup also, my GP told me everything is fine. But I'm worried, doctor, that what is wrong with me?
Okay, I'm sorry for that. You are suffering a lot. Is it this first time you are having this such problem?
Yes, doctor, I'm worried for that. I don't know what happened wrong.
Okay, and is there any pain in your eye?
Yeah, doctor, I told you in the left eye I'm having pain in my
Okay,
left side.
do you see anything double?
No, doctor, not like that. But I see actually blurred only.
Okay, and do you have any headache?
Not whole head is in pain, especially the part of the head surrounding my left eye, doctor. Part of the left side of my
Okay,
head.
and okay, and I'm. Do you have any problem with your speech?
No, no, doctor. I don't have any other problem, doctor, actually, right now. Even then,
Okay,
if you want to know, you
uh,
can ask me.
okay. Any problem with your gait? Any walking
Gait
problem?
means, doctor, or walking? No, 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 doctor. But as I'm, my vision is a blurred one, so a little problem of my walking only for the blurring of the vision in the left side.
Are you taking any medicine other from that anti-diabetic?
No, no, doctor. I'm regularly taking the insulin.
Any hormonal pill or steroids?
No, doctor, I'm not taking any pill.
Okay, and do you smoke?
No, doctor.
Do you drink?
No, doctor.
Okay, do you drive?
No, doctor, I don't drive.
Okay, and are you taking any pill, oral pill?
No, no, doctor, I am not taking pill. I told you.
Okay, and now I am examining you. Do you have any pain, any part of your body?
No, no, doctor. I only pain
Okay,
having in
now,
my left eye. Little bit
okay.
pain is
If you
there.
feel any distress, please let me know. I'll be careful. Okay, now I am examining you as a whole
Okay, doctor.
patient, whether is a patient is obese or any hemiplegic sign or weakness any part.
Patient does not have obesity and there is no hemiplegia.
Okay, and now I am examining the eyes of the patient,
Okay.
and I
What
am
do you want to
sitting
know?
in front of the, and I am seeing any asymmetry
There is no
on the
asymmetry
eye,
in the eye.
any ptosis,
No
and
ptosis.
okay. Now I am examining for the any visual acuity. Can you see my face clearly?
Doctor, in the left
Please
eye, I
close it.
cannot see well. From the left eye, I
Okay.
cannot see well. It is a,
Now I am individually checking for the each eye any visual field.
actually, there is nothing wrong in the visual field. There are some scotoma, the central scotoma in the left eye. The right eye is normal.
Okay. And now I'm seeing the ocular movement.
Movement not in problem, but when patient moves the eye, patient having more pain in the left eye.
And within time, I'm also examining for the nystagmus, looking for any nystagmus.
Actually, nystagmus is very difficult to elicit here because patient having pain, so patient cannot move more and more her eyes.
Okay. Now I am examining you with this torch. It is a torch.
Okay,
It will not harm you,
okay,
and but it will be little discomfort, but it will not harm you.
okay,
Is it
doctor.
okay?
Okay, doctor.
Okay. Now I am approaching the patient 1 meter apart,
Okay, and there is
and
red reflex is normal. There is red reflex is there, so there is no opacity. So this is the retina inside. Okay, so what you are getting, doctor? Can you say your finding actually?
yes, I'm seeing there is a pale disc and sharp margin,
Okay,
and reduce the basal
okay,
count,
okay.
and there is also some silver wiring I also see in this picture, also some
Okay.
retinal. after
Okay.
the silver wearing.
Okay. Then, is anything else you like to comment in the picture of the fundoscopy?
Yes, I also see the surrounding retina. This
Okay.
patient. Now
Okay.
I am anti-clockwise seeing the all quadrants of
Yes.
this retina.
Other part of the retina quite normal. There is nothing wrong.
Okay. Now look at my torso
Okay. Looking
to
to
the
your
light.
torch. So macula is visible, but macula is normal.
Okay. And so, what's your concern?
No, doctor, I am thinking that possibly my eye becoming in damage, because I know that the diabetic patient can have damage to the eye and especially the back of the eye, doctor. 2 minutes left, doctor. 2 minutes.
Yeah, I appreciate your concern, and I will explain it later. And how it is impacting your life.
No, doctor, I'm worried only for today only. It was everything okay one day before. So please tell me, doctor, what happened wrong to my eye, and please do something for me. It will be dangerous, doctor.
Okay, now, okay, after seeing back of your eye, I think that there is, I find something that we call it optic atrophy. That means some part of your back of eye, it is shrinkage.
Okay.
And for that, for this optic atrophy, we have to admit you today for further examination
Okay.
and further evaluation. We'll do some also arrange some scan
Scan of what, doctor?
uh, of
Scan of my eye?
of your brain. You might need some scan of your brain.
Okay.
And meantime, we'll consult with our neurological team.
Okay.
After talking with them, you might need some scan of your brain
Okay.
and some of blood test. Is it okay for you?
Okay. Okay, doctor. Okay. Is it very dangerous, doctor? Will I lose my vision, doctor?
It's very early to say, as today we'll immediately start some medicine,
Okay.
which even might in the injection form.
Okay. Okay.
This may improve your vision. And
Okay, doctor.
after talking with the neurological team, they after getting the imaging result,
Okay, doctor.
they
Okay, doctor.
immediately start the medicine. I hope that.
Okay. Thank you, doctor. Time up.
Meantime, you didn't.
Time up, doctor. Thank you
Okay.
very
Okay.
much,
Thank you.
Dr. Uddin. So, okay, doctor. This is the picture of you, and what is your diagnosis after talking and examining the eye?
It's the case of optic atrophy.
So, what is the type of optic atrophy fundoscopically? Primary, secondary, or consecutive one? Which one you are thinking?
It may be. It's maybe
Your border is very sharp, you told.
secondary optic atrophy.
Secondary optic atrophy. What was the border of the fundus, the optic disc? Was it clear, sharp?
Yes, clear.
So could it be primary or secondary? Anyway, okay, it's primary. So your diagnosis was what? Your diagnosis actually didn't tell to the patient.
No, I didn't tell the patient.
So what is your diagnosis?
It's
Underlying disease actually. If you say that primary optic atrophy, what could be the underlying diagnosis?
maybe a case of multiple sclerosis.
Multiple sclerosis. Why you are thinking so? Can you guess something from the age and gender of the patient?
Yeah, patient female and young
Okay.
lady.
So what investigation you like to do, doctor?
I will do the MRF brain and with the screening of the spine and visual evoked potential
Okay,
of the eye.
good.
And
Thank you, Doctor. Dr. Uddin, your time
this,
is over.
this
So
is
I think, thank you very much. Even then, we can continue discussion with you, as you will be given actually more time for your examination, and we will actually continue few minutes more for the discussion. So you are thinking that this is what I say, the multiple sclerosis as the cause of the primary optic atrophy. So what could be other than this, other than multiple sclerosis? Suppose in an elderly people, what could be elderly male?
it's maybe ischemic optic atrophy
Okay, ischemic optic
and
atrophy. You're right.
maybe secondary
Right.
optic,
Okay.
maybe secondary optic atrophy due to papilledema.
But there is no papilledema, so it should be a primary optic atrophy one. Okay, now come to your diagnosis. If it is multiple sclerosis, you plan that for MRI of the brain. What you want to look for?
Any periventricular lesion.
What is the name of the lesion? Is it plaque?
Yes, any plaque,
Periventricular. So
any old or new, an old or new.
you are especially meaning that this is periventricular. Is it much suggestive for the multiple sclerosis?
Yes, periventricular is suggestive. Also, some for the lesion, which is disseminated time and space older new lesion, who's
Okay.
and number of the plaque.
Okay. Anyway, so you plan for the evoke potential also. Evoke potential for the vision, right? As patient having the visual problem. So what is the significance of evoke potential test over MRI?
Book potential is identified whether it is vision loss is progressive or
Anyway, doctor, we
they
can
can
discuss it.
comment.
We can discuss it a little later. And
Okay.
now your investigation plan also you have told, and management plan, you like to admit the patient in the hospital, and you actually plan for input from the neurology team. Don't you like to include any ophthalmologist?
Yes, I will also include ophthalmologist.
What is your identity, doctor? You are working in where? It's a technical question to you. I'm going back. Have you seen this, Dr. Uddin? You are the
Yes,
doctor
endocrinology
in the
clinic.
criminology clinic. For that, you need referral or input from else.
Yes,
So
yes.
okay, thank you, Dr. Uddin. Your session with you, I think I like to end now, but I like to invite all the participants or those who are hearing now to participate in the discussion. A few minutes we will spend with you regarding diagnosis, investigation plan, and some any technical things. If anybody wants to talk, please. If you want, better you can raise your hand. I will call you. Anybody, please? The basic question is, what is the diagnosis, what is the investigation, and how will we manage the case? This is the basic question really in any exam, whatever the station. Can anybody tell anything here in this case? Farial, may I ask Dr. Farial, please? Can you join with us in discussion? Dr. Farial Chaudhary. Hello, can you hear
Yes,
me?
sir.
Yes. So you find that this is very sharp border here, right? And doctor thought that it will be primary optic atrophy, and some other cases also having the secondary optic atrophy. I will show you the picture later. So do you know why the primary optic atrophy border is very sharp?
Uh,
This is called optic head, right? Optic disc.
Yes, yes, sir.
Head. So actually, the fibers in the optic head structurally remain intact. In the multiple sclerosis, a common phenomena in the optic nerve is the retrobulbar neuritis.
Yes.
So initially, the optic disc remain intact, and we know very popular word that in the multiple sclerosis, patient sees nothing, doctor sees nothing. So doctor sees nothing means that the optic disc may be normal at all, not like this optic atrophy also. So this is the explanation really. Anything, Dr. Farial, in our discussion as a doctor and the patient, do you like to discuss or comment?
Sorry. Yeah.
Don't you write? Didn't you note anything? Anyway, welcoming to our overseas participants as well. Dr. Abdul Hay Ramadan, may I introduce myself with you? Dr. Abdul Hay Ramadan, may I request you also to introduce yourself from where you are here with us? Hello.
Assalamu alaikum.
Hi. Dr. Ramadan, welcome. You are from?
Yes, doctor. How are you? Yeah, from Saudi.
Saudi, fantastic. From which area?
Jeddah.
Oh, it's known to me as well. Okay.
But this is my first time to join like
welcome.
meeting for PACES. Yeah,
very welcome. So actually, what are you doing there now?
I'm working as a chest doctor here in Jeddah.
Which institute it is?
Saudi German Hospital.
Saudi German Hospital, well known to me actually. And I was working in Riyadh many years.
Yeah, in Riyadh, yeah.
Sorry, other colleagues. I was ruminating, really. Don't mind other colleagues. And the King Abdulaziz Hospital, the university, medical city, right?
Yeah.
Jeddah, Hayal Jamia. Hayal Jamia.
Yeah.
I was well known there. Anyway, welcome, doctor. And
thank you.
Just like to hear comment from you, really. Many things. Are you preparing PACES recently appearing or later?
Maybe like applying after like 1 year, inshallah.
Inshallah, okay. So anyway, so what is your comment really? Anything to be discussed or clarified further in our talk?
No, it's because it's my first time. That's why I'm like writing the notes down after you.
Oh, that's good. We hope that we will be getting you in future also. We will continue.
Thank you, doctor. Thank you.
Also. Thank you very much.
Thank you.
Okay. So, Dr. Goma, please. Can you introduce Dr. Ahmed Goma? Hello? Dr. Ahmed Goma. Possibly I'm wrong. If I'm sorry if I don't utter Joma. Anyway. And Dr. Amna. Can you hear me, please?
Yes, doctor.
Yes, please. Can you introduce from where?
I'm from Sudan.
Sudan, welcome. Many fantastic colleagues are from Sudan.
Thank you.
Are you appearing soon in PACES exam? Hello?
No, 1 year, inshallah. After 1 year, inshallah, I will go.
Fantastic. So have you practiced this fundoscopy before? I mean, are you oriented a little?
No, really. No, really. This is time.
Oh, okay, that's good. I think you will be observing us. That's good. Some other doctors also with us today. May I request anyone, please, spontaneously, can you comment, share with us about this? We will go for the next session also. There will be another case. We have to utilize our time as well. If anybody wants
to, thank you, doctor.
Thank you. Dr. Amna from Sudan. Any other one colleague, please? Dr. Sana, Dr. Tahseen, and Dr. Tariq Hamid. Also, I know him a little before. Dr. Tariq Hamid.
Yes, sir. How are you, sir?
Fine. This is actually just for the PACES practice session. There are some practice session also waiting for you as well, as you are actually very new in the part 2.
Yes, sir.
But you enjoyed our talk as a doctor and the patient. This is a surrogation. You already know about that. Any observation you like to comment or discuss? I'm just
actually for me it's first time because we just passed the part 1 exam and we will go for written part 2 written.
That's good. That's good. Thank you, Doctor. Thank you, Tariq. So be with us.
Okay.
So I'm not by specifically one by one I'm asking. Anyway, try your best to be with us for the next session. But I like to say some few words about the optic atrophy really. Just few minutes I like to spend with you. Be attentive, please. Anyway, so especially when you enter this is a very young lady and any unilateral eye problem, just go through these notes. I think it may be a good design for the PACES examination, like a candidate. So patient actually had unilateral vision loss. So there may be some differential diagnosis of the unilateral vision loss. This is one thing. It could be actually a clinical differentials, maybe like that. And it is acute vision loss, not for a long time. So suddenly it could be TIA also, it could be amaurosis, Pujax as well. There may be a branch retinal artery occlusion also, patient having in the risk factor for the vascular occlusive diseases. So anyway, but when you look inside the eye, that is the back of the eye, then you found that a primary optic atrophy. So your differential will be the reason of the primary optic atrophy. So your brow and the TI actually gone there. So now the commonest cause of primary optic atrophy in the young lady especially, and I guided today's doctor colleague, just try to answer from the context of the age and gender. So this is a young lady around 24 or 5 like that, her age, and unilateral acute vision loss. And an incidental finding was a little scotum also found. In practice, actually, in the PACES exam, more maneuvers may not be advised to be done really. It will take more time. The very, very important skill is the fundoscopy. So examiner may guide you. Or doctor wanted to do something more also. Even then, it is better to ask that, sir, I want to do this, I want to do this. Practically, they will tell you that the finding. Okay, doctor, now go for the fundoscopy. They want to see you. This is the best actually maneuver to be seen in eye examination. So I have written the information, what could be the information actually in a case of multiple sclerosis in the unilateral vision loss. This is a chart given for you, just like actually what I say, the checking points. It's called the checklist like that. Very important is that check the vision problem in the one eye or in the both eye. So in the one eye means it's a local disease, unilateral disease, both eyes is generalized disease. Papilledema usually both eye problem, right? It could be papillitis as well. It could be papillitis, edema, maybe reddish hue would be there. Now, other question doctor actually asked about the double vision and headache also. So headache, actually, it should be localized. That means localized means, is it general headache or focal headache? Doctor tried his best to have the information. And the red flag signs are there, really, especially could it be stroke or not? Suppose multiple sclerosis patient may have limb weakness as well, So you don't know from the very beginning what are remaining findings in the patient. So you, in this short time, possible time in the station 5, you'll try your best that what findings could be there. So it is customary, those who are new, that in the strategy of the examination, the PACES examiners are well trained. They know how to guide you really. The examination will be very fine and peaceful. What we experienced in our previous life really. So in the history taking also, we have to take some important history, past history, drug history. And actually our DOAMS had set out a history taking sheet really. If possible, in course of time, we will describe you. From there, doctor tried to ask many things and he asked about the impact. Idea concern also was actually evaluated. Patient actually worried about patient diabetic condition. Could it be diabetic retinopathy? So there was a trick in the instruction. You see that she's patient of 4-year diabetes. So they are given a distractor really. So take care of this. Don't think that it is due to diabetes. It might be something else. So this is the examination plan, and it is enough for you to understand. And the investigation, MRI, okay, this is investigation to exclude the plaques in the brain or even the spinal cord. But I think Dr. Uddin was a little confused about the answer of the evoked potential. In general, the optic pathway, there is a chiasma, and the proximal part is the pre-chiasmatic area part, and the posterior one the post-chiasmatic part. MRI sometimes may miss the findings in the optic nerve, especially in the pre-chiasmatic area. So MRI, if missed to identify the plaques, so evoked potential can take the lead there. So MRI of the brain or the head, whatever you say, including the evoked potential, that means visual evoked potential. Just I like to highlight few words. The evoked potential can be done in different sensory modalities. It may be by the auditory, it may be by the visual. As patient having the visual problem, we are thinking about problem in the optic nerve. So it should be a visual evoked potential test. So then pre-chiasmatic lesion can be visible more. And neurology as well as ophthalmologic review is very mandatory here. So as a station 5 case, really examiner will not have enough time to discuss many things about you. They like to hear just the headlines of the management. What is your diagnosis? What is your investigation plan? And how are you managing? Are you managing right now? Or you're referring or planning for the admission in the hospital? So Dr. Uddin tried his best to say in the admission, because he's a junior doctor working in the endocrinology. So how much an endocrinology doctor know about the disease? So it is better to admit the patient. And just additional information in the elderly people, the sudden painful unilateral vision loss, like a similar case, just age and gender, especially age is guiding you to think about some other causes. So I think this picture, if may I request you to make a snapshot, it will be, I think, easier for you to make a case smoother for you to overcome a case from the especially eye cases in the station 5. And to inform you that in the station 3 also, in the neurology station also, sometime, though it is now given very rarely, do fundoscopy and do the relevant test. Sometimes it might be the instruction. I think it will be helpful for you for this practice session. So this is overall the optic atrophy of this case, and this is the text for you. And this is the primary, secondary, and the consecutive optic atrophy. The next picture will tell you the detail. Just to inform you that why the optic atrophy, the border is sharp, not distorted. The reason is that the optic nerve head, that means the optic disc architecture is intact, though nerve is in problem. But if persists long time, there may be blurring of the optic margin, then we will term it secondary optic atrophy, especially as a consequence of the chronic papilledema, papillitis, and ischemic optic neuropathy. This is the consecutive optic atrophy. Disease in other part of the retina, that is maybe the vascular disease of the retina or the retinal damage, subsequently involvement of the optic atrophy. And very truly speaking, this classification is not very good classification, though traditionally as fundoscopic picture, it is told that a fundoscopic classification, any disease from the secondary and the consecutive can do this change actually. So this is a picture just to show you how to identify the primary, secondary, and the tertiary one. Sorry, not the tertiary, the consecutive one, sorry. So this is, you see the retina is in problem. Those who have seen retina previously normal, anybody can understand that there is some exudation, right? The vascular attenuation. So retina is in disease. As a part of the retina, optic disc also is in disease. This is the consecutive one. And this is the blurred vision, sorry, blurred optic disc margin. This is a secondary, usually consequence of the papilledema, papillitis, and the ischemic problem of the retina, the anterior ischemic optic neuropathy. I think my advice to you, just try to learn what is anterior ischemic optic neuropathy. This is not time to discuss detail about. And the case you have seen already now. This is the primary optic atrophy by optic nerve chiasma lesion. Maybe compression is there, acute compression by the pituitary tumor, surrounding. And some hereditary disease also, family history was important to know about. And there may be some nutritional optic atrophy. So this is my talk. I think you know that vitamin B12 deficiency can cause optic atrophy. Up to this, and now the picture to you. Can anybody wants to comment? What could be? Anybody, you can write or you can talk also. We are not huge amount of number really. Anybody want to say? Even Dr. Uddin also can comment. This is a fundoscopic picture. What about the optic disc?
This is papilledema, sir.
Papilledema. Papilledema. Blood margin. Is a blood margin is there? There are some. Anyway, this is a white optic disc, no doubt. In general, white optic disc. Okay. Can anybody say anything more here? Could it be primary optic atrophy or secondary one? If it is, we mean that white retina means optic atrophy. Dr. Uddin? No gazing?
Yes, sir. Possible.
Possible. So margin is not actually clean cut. It's a white optic disc and the margin is not. It is a diffuse margin. So first look at the whiteness of the optic disc. This is optic atrophy. Atrophy actually a misnomer though. Pathologically, the optic atrophy is not a well-fit word here. Even then, traditionally we are telling margin is not clear. So it's a secondary optic atrophy. And it is about, for what I will tell a little later. If anybody wants, please, you can share. So this is the finding really. The arteritic ischemic optic neuropathy. The disc is pallid. Pallid means pale, white. And disc is edematous. For that, you are not looking much vessels here. Associated with hemorrhage, small red areas are there, and adjacent white areas, these are termed as cotton wool spot. You know in the meantime about cotton wool spot. So this is actually edematous disc, white diffuse border. It is more suggestive of arteritic ischemic optic neuropathy, especially in the elderly people. We may expect that in the giant cell arteritis, we may expect fundoscopically this like a picture. So if one word is arteritic, another word will be non-arteritic. That means without arterial inflammation, there is a less blood supply, right? It is called non-arteritic ischemic optic neuropathy. This is the right side picture. That has been from the screen really you see, but in the screen they are telling this is the left one, I think. Yes, this left and this one the right. So what we have seen, this one arteritic white areas with cotton wool spot. But this is not white. It is more reddish. There is edema. You see why edema I am telling? The vessels are not much clearly visible. So edema are here. And then there is no border clear cut. So this is actually secondary optic atrophy. It is not always white. There is redness also. This is ischemic. So this is the hyperemia of the disc. So this is the difference between ischemic and non-ischemic. Non-ischemic means arteritic, rather to say arteritic, non-arteritic ischemic. Word is a little difficult to say, right? Anterior arteritic.
So how can we differentiate from papilledema this non-arteritic optic atrophy, sir?
Oh, this is also papillitis. This is papilledema. There are some misnomer words really. Papilledema usually will be a bilateral feature. There are also edema. There is no doubt. There are also edema. But in general, we use the word, the papilledema for the bilateral finding. Bilateral finding. This is a textbook knowledge only, nothing else. This is also edema, no doubt. Okay, Dr. Uddin. The concept is clear. So this is a break time really. I think if you don't have any query or discussion regarding this, we can take a deep breath, few seconds, and switching to the next case, please.